Spine Society Oncology group has been to think about opportunities to share new ideas in dealing with spine tumors. And often this means inviting people who are not spine surgeons and really seeing what can be learned from different aspects and different perspectives. My name is Dan Schuba, and as one of the co-chairs of the North American Spine Society Spinal Oncology Group with Dr. Joe Schwab, we thought this was an important opportunity. With one of our other leaders who've thought about really bringing the Seattle Science Foundation was the idea of Dr. Mohammed Mackey, who really thought of this, and this was his brainchild. And I'm going to introduce him now so he can make some comments about this event and future events.
Thank you for those kind words. I'm one of the spine surgeons at the Cleveland Clinic. I'm very, very excited to introduce this new collaboration between the Seattle Science Foundation and NAS to bring out new and exciting topics on spine oncology. We'll be hosting this event on average about once every month to once every other month. It's usually going to be the first Monday of the month. And we are excited to kick off this pilot session with Dr. Joe Schwab, who is the Director of Spine Oncology for Orthopedic Surgery at Cedars-Sinai. And I will hand off, without any further ado, Dr. Schwab, I'm going to hand the podium to you.
Thanks very much, Mo and Dan. I am happy to host the inaugural podcast, and we have two outstanding guests. The first guest is Manuela Palmerini, who comes to us from University of Miami by way of the Rizzoli Institute in Bologna, Italy, where she established herself as a world leader in the treatment of bone and soft tissue sarcomas, has been a leader in clinical trials, and has expertise in immunotherapy. Also would like to introduce Sonia Schrepfer, who is now of Cedars, but was by way of UCSF and Stanford. She really is at the razor's edge of CAR T therapy and the developing new techniques in CAR T therapy. And we're going to be discussing immunotherapy at large with an emphasis on lymphocytes. I'd like to give a little bit of background just because I think it helps put the discussion in context. Joseph Murray won the Nobel Prize for performing the first organ transplant. This was 1954, Brigham and Women's Hospital in Boston. And research at that time in immunology really focused on trying to understand self versus non-self, how are organs rejected. And this led to our understanding of the HLA class 1 and class 2 antigen system, which of course is extremely important in immunology generally, but also in cancer. And in 1971, Richard Nixon declared his war on cancer. And with that, he promised $1.5 billion, which was a lot of money in 1971, towards funding the NCI. And so many labs which had been focusing on transplantation transitioned into cancer care. And one of those labs was in Scripps in San Diego. And actually, my father-in-law, Saldano Ferroni, was one of these researchers. So he transitioned from focusing on HLA and transplantation to understanding HLA and cancer. And his work led to an understanding that many cancers actually suppress the expression of HLA class 1 antigens, and that makes them invisible to the immune system. And so that was a nice finding on his part. One of his colleagues from that same lab was James Allison. And James Allison was focusing on T cells. Later, James Allison discovered CTLA-4. And his discovery of CTLA-4 won him the Nobel Prize in 2018. So CTLA-4 is part of a class of molecules called checkpoint molecules. And that leads me to my first question for Dr. Palmerini. Emanuela, I wonder if you could explain to our audience what are checkpoint molecules and what is checkpoint inhibition, and how does it relate towards the treatment of spine tumors?
Thanks, Joseph, for the kind introduction and for bringing up this interesting topic. I think it's very interesting because we should be able to recognize and eliminate the tumor, as we do with a virus or bacteria. But the presence of this immune checkpoint on the surface when interacting with tumor cells creates a sort of energy. So the immune checkpoint inhibitors linking to the PD-1 on the surface of tumor cells release this energy on inhibition. And when we combine PD-1 and CTLA-4 for many clinical trials, the activity is much more stronger. Although there are other and several ways to stimulate and to collaborate in between these targeted drugs. And recently, this year, there are several trials with immune checkpoint inhibitor with anlotinib, for example. And this study was published in a specific subset, chondrosarcoma. The trial included 40 patients, 20 chondrosarcoma and 20 dedifferentiated chondrosarcoma. And I want to start with this study because it confirms results from the SARC 028 study that the dedifferentiated chondrosarcoma really shrinks. So objective response rate 30% means that 3 patients out of 10 have a reduction of their tumors maximum diameter above 30%, which is really unusual in bone tumors.
Manuela, I think that's a great point. And normally when surgeons are faced with chondrosarcoma, particularly dedifferentiated chondrosarcoma, we think really there's only one thing that you can do. You either don't treat them at all or you treat them with surgery. But it looks like, and certainly with dedifferentiated, that may not be the case any longer. So I think that's important for surgeons to be aware.
Yeah.
Go ahead, please.
No, I want only to talk the other combination that I think for surgeon it's particularly important to consider in 2025 is the combination of immune checkpoint inhibitor like pembrolizumab with radiation therapy. Last year, November 2024, there is an important trial in this time in soft tissue sarcoma, but I think the hypothesis is translational across several histotypes. So they included undifferentiated pleomorphic sarcoma and the differentiated liposarcoma because we already know that some histotypes among soft tissue sarcoma like alveolar or OPS or the lipo respond better. So their immune infiltrate is different. And the study was positive, showing that 65 patients treated with the radiation therapy and pembrolizumab before surgery, as compared to radiation therapy alone and then surgery, had a much higher, more than 15% higher progression-free survival. And this means a lot. It means that we can actually, in the setting of localized disease, offer a great impact on the very initial treatment, which we really, really care and love because it means having more patients happy and not relapsing, which is a major challenge. So most of the trial now are bringing immune checkpoint inhibitor earlier in the treatment. For example, in Spain, there is a trial for osteosarcoma combining methotrexate, cisplatin, and adriamycin with nivolumab. So I think that there is a change of paradigm we are witnesses now.
That's great. I wonder, there are some targeted therapies that really have problems with, say, wound complicated, like VEGF inhibitors, for instance. Surgeons learn pretty quickly that if you operate on those patients recently after they've been treated, you're going to have a problem with a wound. What sorts of things do you worry about, or are there anything to worry about with checkpoint inhibition and in the perioperative setting that surgeons ought to consider?
So it's a very good question. Actually, after 20 years at Rizzoli, I know very well the question from my surgeon. This patient for lung, for example, lung tumor pathological fracture just had this specific treatment, and so unlike chemotherapy, of course, immune checkpoint inhibitor, they do not harm the bone marrow, so you don't have any problem with, for example, anemia or leukopenia or thrombocyte. I mean, any toxicity of that kind is very, very mild. But they can cause, for example, pneumonitis, colitis, all autoimmune like thyroiditis. So I think it's very different. If the treatment is well established, it's unlikely that all those things are going to happen. But we know very well that any kind of stress, like surgical stress, it's a trigger for immune system. So usually, for most immune checkpoint inhibitor, it is recommended that they are suspended at least 2 weeks, 2 to 4 weeks to be in the safer part, but they do not affect wound complication rate as proven for VEGF inhibitors.
So if you can be safe, wait a few weeks, but it's not, you probably can go ahead if it's an emergency sort of a thing.
I mean, yeah, in an emergency situation, I think you can discuss with your treating oncologist, but I think that the balance could be on in intervening rather than now.
Great. I want to ask a question of Sonia Schrepfer a bit, and we are certainly going to come back and have other opportunities for questions. But Sonia, you're in an interesting area of immunotherapy and have done a lot of incredible work in CAR Ts in particular. But many of our audience may not even know what a CAR T is. I wonder if you might be able to explain what a CAR T is generally.
Yeah, happy to. So CAR T stands for chimeric antigen receptor T cells. And what it really is that you use the patient's immune cells, the T cells, and you basically program them that they know the antigen of the tumor. So let's say you're interested in eliminating a CD19 positive lymphoma, you would create a T cell from the patient that has a receptor for the CD19, so an anti-CD19 CAR T. And usually how it works is that the patient comes into the hospital, it's a normal blood draw, and then the T cells get selected, and then you engineer that CAR T, that receptor, on the patient's T cells. You expand them ex vivo, and when you have enough T cells, they do get reinfused back into the patient after lymphodepletion. The lymphodepletion is always a point of discussion. Why do you need it? So the field, I think, agrees that you need lymphodepletion to create a cytokine milieu for the CAR Ts you are infusing into the patient, that they can expand when they see the tumor. And maybe you also need the lymphodepletion to create the niche for the T cells. And what happens is that those CAR T cells are then the receptor sees the tumor, the CD19 on the tumor cells. The CAR Ts are expanding and they really go after the tumor and kill the tumor quite rapidly if it works nicely. So the goal is really to use those educated immune cells from the patient to see the tumor and fight the tumor and eliminate it completely.
But it's really very, very personalized, probably the most personalized care, because you're using their own lymphocytes to attack the tumor.
Yes, and it's very time and cost intensive. And unfortunately, I think the biggest disadvantage is that you never know if you are able to create the CAR T cells from the patient in time. And if those CAR T cells are effective, because you isolate them from a tumor patient, so the immune system by definition is already weakened. So that could affect that your CAR T cells, when you generate them, maybe you're not able to generate them, or you can generate them, but if you infuse them into the patient, that they get exhausted quite fast. So the question is really, how could we overcome that hurdle? And one strategy is that you think about, instead of autologous CAR Ts, allogenic off-the-shelf CAR Ts, meaning you have a healthy donor. And then you infuse those CAR T cells from a healthy donor into the patient. Then you could do it really off the shelf. Whenever the spine surgeon needs those CAR Ts, he can get the CAR Ts off the shelf and infuse them immediately.
And the immune system does not reject them.
Yeah, the great point. So if you do it allogenic, so the T cells from another person, you have to overcome that allogenic barrier, so rejection. So the immune system would reject those allogenic CAR T cells. And I'm in the field where we try to use genetic engineering to create what we call hypoimmune CAR T cells. So basically, you modify the CAR T cells by not only putting in the CAR receptor, but you also knock out like the MHC molecules we discussed that the tumor basically hides from the immune surveillance, and that you basically engineer them, that you can infuse them into the patient without rejection, that they really can long-term persist in the patient.
The concept is, if I understand correctly, that you don't necessarily have to be in a specialized center that can produce a CAR T. You can actually purchase these from any center. And then the idea that many of our surgeons will be seeing this in patients, likely in our lifetime.
I really, truly hope so. And it's really off the shelf. It's meant to be for anyone, anytime, anywhere. That's really the big goal, that it's a frozen product and you thaw it at the bedside. You infuse the cells for your patient, and that you don't need specialized centers.
One of the complications that we often hear about in patients who have CAR T therapy, right? By the time you get to CAR T therapy, you're very sick. You're really at the end of the stage 4, sort of thing before you qualify. But you can get something called cytokine storm, and that can be very serious, right? Are any of these the allogeneic approach, is that helping with that concept as well? How does it help?
So what a cytokine storm really tells you is that the CAR T therapy was effective. So you give the CAR Ts, they find the tumor, they expand, and they can really kill tumor cells quite fast. But they do that by releasing like perforin and coenzyme, so molecules that make holes into the tumor cells. And if the tumor cells now die, a lot of them at the same time, you get that cytokine release, and that can give you really severe side effects. So we do hope with genetic engineering that you not only can generate an allogenic product that doesn't get rejected, but that you can basically use other strategies to make those CAR Ts better than an autologous approach, meaning that they might expand in a way that you can reduce this cytokine release syndrome, meaning that maybe they can overcome from solid tumors that microenvironment we discussed with PD-L1. So if the receptor, the tumor has expressed high PD-L1, you could think about why not injecting a PD-L1 receptor knockout CAR T. Then it doesn't matter that the tumor expresses it. So there would be in the future, I hope we will see a lot of elegant approaches that not only overcome that allogenic barrier, but really make the CAR Ts strong and safe warriors, and also that they can really persist long-term in our patients, that if the tumor would relapse and come back, the cells are still in the body and clear immediately, that you don't get the relapse, etc.
Great. I have a general question for either Manuela or Sonia. The idea when you think about especially when we're talking about primary tumors, say osteosarcoma, right? The matrix is bone. Or chondrosarcoma, you have these abundant glycosaminoglycans, huge amount of very large molecules, all very negatively charged. Or chordoma, similarly, huge molecules negatively charged. And it's been shown that that actually even the charge itself can be a deterrent of T cells infiltrating into the tumor microenvironment. And so one argument would be that these will never completely clear these tumors because they can't get through the actual environmental barrier. I don't know. Have you thought about that, either of you, and any thoughts on that issue?
Yeah, Dr. Palmarini.
No, I think that it's a good point, but the results we have been reporting prove that most important is the tumor microenvironment composition. So I think one of the biggest player is CD8 infiltrate. So immunotherapy works when CD8 is there. And as proven in several studies, Tregs and also macrophage are more, I think, for a prognostic point of view, but of course it depends on the drug. while the accessibility of the lesion, I think it's already show that it's good because of this drug were effective. Although most of the trial included the patient with metastasis rather than primary tumor, so we will definitely need to wait for that trials I was mentioning in the neoadjuvant bone tumor setting, but it's already ongoing, so we will know soon.
Yeah, and so the access to the tumor is a big issue for the CAR T. So in hematologic cancers, we know they work for solid tumors. There needs to be more work done. We need to think through how can the T cells really access the tumor. For the spine surgeons, I could imagine you first shrink the tumor with surgery. By that time, you have broken the barriers. And if you now do the CAR T infusion, it's most likely easier to access the leftover tumor cells to then really completely eliminate the tumor. But there is much more work that needs to be done for the CAR Ts.
What would you think about the surgeon's role changing, and they actually going to do a direct injection of, say, CAR T cells directly into the tumor, or maybe interventional radiology does that? Is that something that you think could work, or something for the primary tumor, I'm saying?
Yes, absolutely. The direct injection is one big advantage for the CAR Ts. You inject them directly and you can repeat that. So if you think about the allogenic strategy we discussed, you have them off the shelf, you can do redosing and really apply the CAR T cells directly in where they are needed. Then they will, of course, expand in the germinal centers. They will not stay there, but they will basically have that first contact to the tumor there.
I don't have the direct experience, but with CAR T injection, but there are a new generation of intratumoral treatment for soft tissue sarcoma. Although I think that it's very difficult because open a new window of potential complication and confounding factor. I mean, I'm mentioning for example, the injection into a metastasis and then all the pleural effusion. So I think it's harder to assess. But while for spine tumor in particular, I think might be an opportunity, and immunotherapy combined, for example, with the radiation therapy or carbon. There are not many centers doing carbon therapy, but I have to mention the Rizzoli experience with chemotherapy and carbon therapy. So the idea is to do intralesional pre-planned intralesional surgery, but that for me it's like a very very unusual planning, but with carbon after. So I think for that kind of approach, putting an immune checkpoint inhibitor in the cocktail would be probably a good thing, because it might be infused for several months after local treatment.
Yeah, it's a very controversial area, and really hotly discussed among surgeons and radiation oncologists, the treatment of primary tumors with intralesional subtotal or even complete resection combined with carbon ion or proton ion radiation. That's very, very much a controversy, but it might become more palatable if you have some sort of a combination of with either checkpoint or even a CAR T. If you're going to do an intralesional gross total and then you're leaving CAR T behind, for instance, something of this nature, I think could be interesting to people. But it's hotly debated. The surgeons, many surgeons in our group have spent our entire career learning how to cure cancer with en bloc spondylectomy, and then somebody says you don't need that anymore. You say, well, I don't know.
Yeah, I was surprised as well, but coming from the team of Gasparini, I give it a try.
Absolutely. Well, we have about 5 minutes left. I want to allow other people to ask questions, Dan or Mo, or I don't know if our audience can ask any questions.
If I could ask the panel a question from a surgeon who obviously his perspective is limited in this area. So when I think about a patient who has a primary aggressive tumor, or maybe metastatic, you choose your pick, and the surgeons out there often will group chemotherapy and immunotherapy together. They just say medicine, not radiation, not surgery, but medicine. And obviously, conventional is a very destructive. It's killing things. It's a poison, and immunotherapy is a modulation. And so, simply put, are these used together, or are they always separate? In other words, I could imagine that conventional chemotherapy would destroy not only normal tissues, but some of the therapies that you try to give, or at least deranges some of the monoclonal antibodies or the cytokines or the cellular therapies or the checkpoint inhibitors. So is this something where it's an either or is it choreography where the oncologists have to think about the tumor and do it in stages? Because if the surgeons know this, that it has to be choreographed, they should be aware of that.
I can reply. We need to know the histology. We are oncologists, and because there are several histotypes, and some patient, for example, with an alveolar metastatic, 1 out of 2, they would respond to immune checkpoint inhibitor only. So, and they are chemo resistant, so why bother? On the other end, for a metastatic synovial sarcoma, for example, if you can give high-dose ifosfamide, again, the objective response rate is it's better than immune checkpoint inhibitor. And combining is going to be the future, but there are no data for each histotype in the metastatic setting. Now that they are generated in the neoadjuvant setting where we have a more surrogate of response. But so to answer your question, depends from the histology, and usually they're used in sequence because we want to chronicize the disease, so we don't, unless there is proven synergism and superiority, we don't want to combine toxicity. So for now, it's still in a monotherapy, but it's very, very histology and patient driven decision.
I mean, for the future, I would love to see us to move away from this unspecific chemotherapy and combine more elegant, targeted strategies like Dr. Palmerini's checkpoint inhibition, for example, combined with a CAR-T cell therapy after the surgeon has removed the accessible tumor would be something I would love for our patients to see in the future, that the choreography is more specific and not with all the toxicities we have at the moment.
And if if I can close, the something very, very in the future I would love to see is theranostic. There are some the surfaceome for bone tumor osteosarcoma. It's incredible, and there are leucine 15 receptor target very, very appealing. For example, with the antibody drug conjugate, and there are already mice model of osteosarcoma where immuno agent work very well with this specific surface inhibition. So I think the more we know the surface, the more it is. We will combine newer strategies.
I must say that I feel much more optimistic about the future of oncology after listening to Dr. Schrepfer and Dr. Palmerini. So this is we will end on a very positive note, and I've learned a great deal, and truly appreciate both of you being here and educating us. I'd like to thank Hannah from the Seattle Science Foundation, and Mo and Dan, of course, as always, for your leadership and your ideas. And thank you, everyone, for participating.
Thank you.
Thank you.